Hi everyone, my name is Deanna Hunt and I'm one of the instructors here at Mount Carmel College of Nursing. Today we're going to be reviewing basic principles of antimicrobial therapy. Now, modern antimicrobial agents, they actually had their debut a while ago in 1930s and 40s. And as a result, they've greatly reduced morbidity and mortality from infection. Now, as newer drugs are introduced, our ability to fight infections increases even more. Today we're going to focus on two principal themes though. The first is microbial susceptibility to drugs, with an emphasis on resistance, and the second is clinical use of microbials. Before diving into antibiotics, it's important to discuss selective toxicity. Now, selective toxicity is defined as the ability of a drug to injure a target cell or target organism without injuring other cells or organisms that are in intimate contact with the target. If it were not for selective toxicity, if antibiotics were as harmful to the host as they are to the infecting organisms, these drugs would have no therapeutic utility. So as a refresher, selective toxicity is toxic to microbes but harmless to the host. This is due to the differences in cellular chemistry of mammals and microbes. And usually this works by disruption of the bacterial protein synthesis in cell wall and inhibition of enzyme unique to the bacteria. There are different ways to classify antibiotics, which are susceptible organisms and mechanism of action. Today we're going to talk about both. Specific to susceptibility, antibiotics differ widely in their antimicrobial activity. Some agents, called narrow-spectrum antibiotics, are active against only a few species of organisms. In contrast, broad-spectrum antibiotics are active against a wide range of microbes. As discussed later, narrow-spectrum drugs are generally preferred to broad-spectrum drugs. Mechanism of action is obviously going to be how the drugs work. First, we're going to talk about classification by susceptible organism. The next few tables we're going to review shows the three major groups: antibacterial drugs, antifungal drugs, and antiviral drugs. Each table subdivides the antibacterial drugs into narrow-spectrum and broad-spectrum agents, and they indicate the principal classes of bacteria against which they are active. For this specific table, it describes the narrow-spectrum antibiotic group classification, and as you can see on the right, they're the specific drugs that are incorporated within this group. This table describes the broad-spectrum antibiotic group classification, which, as you can see on the right, includes some penicillins, cephalosporins, tetracyclines, among others. This table discusses different antiviral drugs, some of which you might be familiar with, including acyclovir, among others. And lastly, we have the antifungal group classifications, which includes the azoles, which you may be familiar with. Now we're going to talk classification of the antibiotics specific to mechanism of action. How the drugs work, or the mechanism of action, includes drugs that inhibit bacterial cell wall synthesis or activate enzymes that disrupt the cell wall. These drugs include penicillins and cephalosporins, and they weaken the cell wall and hence promote bacterial lysis and death. Then you have drugs that increase cell membrane permeability. Drugs in this group increase the permeability of cell membranes, causing leakage of the intracellular material. Third, there's drugs that cause lethal inhibition of bacterial protein synthesis. This includes the aminoglycosides, including gentamicin, and they're the only drugs in this group. We do not know why inhibition of protein synthesis by these agents results in cell death. Fourth, we have drugs that cause non-lethal inhibition of protein synthesis. Now, like the aminoglycosides, these drugs, including tetracyclines, inhibit bacterial protein synthesis. However, in contrast to the aminoglycosides, these agents only slow microbial growth, and they do not kill bacteria at clinically achievable concentrations. Fifth, we have drugs that inhibit bacterial synthesis of DNA and RNA, or they just disrupt the DNA function. These drugs inhibit synthesis of DNA or RNA by binding directly to nucleic acids, or by interacting with enzymes required for nucleic acid synthesis. They may also bind with DNA and disrupt its function. Membranes of this group include the metronidazoles and fluoroquinolines, including Cipro. Sixth, you have the antimetabolites. These drugs disrupt the specific biochemical reactions. The result is either a decrease in synthesis of essential cell constituents or synthesis of non-functional analogs of normal metabolites. Examples of antimetabolites include trimethoprim or the sulfas. Seventh, the last one, are drugs that suppress viral replication. Most of these drugs inhibit specific enzymes, including DNA polymerase or reverse transcriptase, that are all required for viral replication and ineffectivity. The next few tables will describe the antibacterial group classification. You can see in this table, the drug classes described are drugs that inhibit cell wall synthesis, drugs that disrupt the cell membrane, and bactericidal inhibitors and bacteriostatic inhibitors, and each of their representative antibiotics on the right. Now, the antimicrobial drugs, they fall into 7 major groups based on mechanism of action. Properties of each of these 7 major classes are discussed briefly, but when considering the antibacterial groups, it may be useful to distinguish between agents that are bactericidal and agents that are bacteriostatic. Now, as a reminder, bactericidal drugs are directly lethal to bacteria at the clinically achievable concentrations. In contrast, though, bacteriostatic drugs can slow bacterial growth, but they do not cause cell death. When a bacteriostatic drug is used, elimination of the bacteria must ultimately be accomplished by host defenses, and this is the immune system working in concert with the phagocytic cells. Drugs classified within this table are drugs that interfere with synthesis or integrity of bacterial DNA and RNA, antimetabolites, and drugs that suppress viral replication. So as you can see, if you're using the classification by mechanism of action, on the left you see drugs that interfere with synthesis or integrity of bacterial DNA and RNA. On the right you can see 3 drug classes that are included in this, including the fluoroquinolines and metronidazole. Listed on this slide are drugs that also suppress viral replication. Next, we're going to talk about antibiotic resistance. Now, bacterial resistance to antibiotics may be innate, natural, or inborn, or acquired over time. Discussion right now is going to be limited to acquired resistance, which is of much greater clinical concern than innate resistance. Now, over time, an organism that had once been highly sensitive to an antibiotic may become less susceptible, or it may lose drug sensitivity entirely. In some cases, resistance develops to several drugs. Acquired resistance is of great concern in that it can render currently effective drugs completely useless, thereby creating a clinical crisis and a constant need for new antimicrobial agents. As a rule, antibiotic resistance is associated with extended hospitalization, significant morbidity, and excess mortality. Organisms for which drug resistance is a current serious problem are listed here within the notes. The next few slides are going to be tables that describe different bacteria and the resistant drug. The first column describes the bacterium, the second describes the resistant drug, the third describes the resistant mechanism, and the last column describes alternative treatment options. As you can see in this slide, the bacterium of interest is Enterococcus faecalum. You can see all the different resistant drugs, the resistant mechanisms, but the alternative treatments you could use. For this slide, the first column describes the bacterium, which in this case is Staph aureus. The second again describes the resistant drugs. The third describes resistant mechanisms, and the last column describes the alternative treatments. Again, the first column describes the bacterium, which in this case is the Enterobacter species. The second describes the resistant drug. The third describes the resistant mechanism, and the last column describes the alternative treatment options. Again, the first column describes the bacterium, which is the Klebsiella species. The second describes the resistant drug, third describes the resistant mechanism, and the last column describes alternative treatment options. Again, the first column describes the bacterium, Pseudomonas aeruginosa. The second describes the resistant drug, third describes the mechanism of action, and the last describes alternative treatment options. The first column describes the bacterium, Acinetobacter baumannii. The second describes the resistant drug, the third describes the resistant mechanism, and the last column describes alternative treatment options. Now lastly, the first column describes the bacterium, C. diff. The second describes the resistant drug, which is metronidazole in this case. The third describes the resistant mechanism, and the last column describes alternative treatment options. Now, it's incredibly important to just process all of these slides and bacterium that we just reviewed and the significance of this. There are clearly a significant number of drug-resistant bacterium out there, and the concern is that this number is only going to grow. Now we will discuss microbial mechanisms of drug resistance, including reduction of drug concentration at its site of action, alternation of drug target molecules, antagonist production, and drug inactivation. First, we're going to talk about reduction of drug concentration at its site of action. Now, for most antimicrobial drugs, the site of action is intracellular. Accordingly, if a bug can reduce the intracellular concentration of a drug, it can resist harm. Two basic mechanisms are involved. First, microbes can seize active uptake of certain drugs, tetracyclines and gentamicin, for example. Second, the microbes can increase active export of certain drugs, tetracyclines, fluoroquinolines, macrolides, for example. Now we're going to talk about alteration of drug target molecules. Most antibiotics, like most other drugs, must interact with target molecules, or receptors, to produce their effects. Hence, if the structure of the target molecule is altered, resistance can result. For example, some bacteria are currently resistant to streptomycin because of structural changes in the bacterial ribosomes, the sites at which streptomycin acts to inhibit protein synthesis. Now we're going to move on to antagonist production. Now, in rare cases, a microbe can synthesize a compound that antagonizes drug actions. For example, by acquiring the ability to synthesize increased quantities of PBA, some bacteria have developed resistance to sulfas. Lastly, we're going to talk about drug inactivation. Microbes can resist harm by producing drug metabolizing enzymes. For example, many bacteria are resistant to penicillin G because of increased production of penicillinase, an enzyme that inactivates penicillin. In addition to penicillins, bacterial enzymes can inactivate other antibiotics, including cephalosporins, carbs, and fluoroquinolones. Ultimately, all of the alterations in structure and function discussed previously result from changes in the microbial genome. These genetic changes may result from either spontaneous mutations or from acquisition of DNA from an external source. One important mechanism of DNA acquisition is conjugation with other bacteria. First, we're going to talk about spontaneous mutation, which produces random changes in a microbe's DNA. The result is a gradual increase in resistance. Low-level resistance develops first. With additional mutations, resistance becomes greater. As a rule, spontaneous mutations confer resistance to only one drug. Next, we're going to talk about conjugation. Conjugation is a process by which extrachromosomal DNA is transferred from one bacterium to another. To transfer resistance by conjugation, the donor organism must possess two unique DNA segments, one that codes for the mechanism of drug resistance and one that codes for sexual apparatus required for DNA transfer. Conjugation takes place primarily among gram-negative bacterium. Now, there is a relationship between antibiotic use and the emergence of drug-resistant microbes, and that is the use of antibiotics promotes the emergence of drug-resistant microbes. However, please note that although antibiotics promote drug resistance, they are not mutagenic and do not directly cause the genetic changes that underlie reduced drug sensitivity. Spontaneous mutation and conjugation are random events whose incidence is dependent on the drug use. Drug use simply makes conditions favorable for overgrowth of microbes that have required mechanisms for resistance. When talking about the emergence of drug-resistant microbes, it's important to talk about superinfections. Now, a superinfection is defined as a new infection that appears during the course of treatment for a primary infection. New infections develop when antibiotics eliminate the inhibitory influence of normal flora, thereby allowing a second infectious agent to flourish. A common example of a superinfection is the development of vaginal candida infection in a female who's treated with a broad-spectrum antibiotic for a urinary tract infection. Because broad-spectrum antibiotics kill more normal flora than do narrow-spectrum antibiotics, superinfections are more likely in patients receiving broad-spectrum agents. To better prevent antimicrobial resistance, we need to talk about antimicrobial stewardship. Now, many organizations have begun to address the issue of antibiotic resistance in healthcare. In 2012, the Infectious Disease Society of America, in conjunction with the Society for Healthcare Epidemiology of America and the Pediatric Infectious Disease Society, released its first statement of antimicrobial stewardship. The statement includes 5 recommendations with suggestions for monitoring, education, and research to assist in prevention of antimicrobial resistance. The link can be found in the notes section of this PowerPoint. Additionally, the American Board of Internal Medicine Foundation created the Choosing Wisely campaign in 2012 to decrease the amount of wasteful practice in healthcare. More than 70 specialty organizations have contributed to guidelines to promote for evidence-based practice. Many of these guidelines address the appropriate use of antimicrobial therapy. Again, Choosing Wisely can be found in the links section of these notes. Lastly, the Get Smart for Healthcare campaign, initiated by the CDC, provides information on proper use of antibiotics in humans and animals. The campaign has 3 objectives: to promote adherence to appropriate prescribing guidelines, to decrease demand for antibiotics among healthy adults and parents of young children, and to increase adherence to prescribed antibiotics. Again, the link can be found in the notes section. In addition to the CDC campaign, in 2014, the Interagency Task Force on Microbial Resistance published an update to its original publication, a public health action plan to combat antimicrobial resistance. This updated action plan discusses 4 focus areas developed to increase resistance to antibiotics. Focus Area 1 is surveillance, prevention, and control of antimicrobial resistant infections. Focus Area 2 is research. Focus Area 3 is regulatory pathways for new products. And the last focus area is product development. Next, we're going to talk about selection of antibiotics now that we understand its classes, the categories, and antimicrobial stewardship. When treating infections, the therapeutic objective is to produce maximal antimicrobial effects while causing minimal harm to the host. To achieve this goal, we must select the most appropriate antibiotic for the individual patient. When choosing an antibiotic, 3 principal factors should be considered. 1, the identity of the infecting organism. 2, drug sensitivity of the infecting organism. And 3, host factors, such as site of infection and the status of host defenses. For any given infection, several drugs may be effective. However, for most infections, there is usually one drug that is superior to the alternatives listed above. The drug of first choice may be preferred for several reasons, such as greater efficacy, lower toxicity, or more narrow spectrum. However, when possible, the drug of first choice should always be used. Alternative agents should only be used when the first choice drug is inappropriate. Conditions that might rule out first choice drugs include allergy to the drug of choice, inability of the drug choice to penetrate the site of infection, and heightened susceptibility of the patient to toxicity of the first choice drug. So as you can see on this slide, there's common infections caused by common bugs, and this includes bacterial meningitis, sinusitis, pharyngitis, endocarditis, so on. And on the right includes the bacteria that actually cause these. This is going to help us decide the most appropriate treatment. The next few tables on the slides, we're going to view antibacterial drugs of choice specific to the organism and first choices and alternatives. For this table, we're looking at specifically gram-positive cocci. The first column you can see reveals the organism specifically for gram-positive cocci. The second column is the drug of first choice, and the third column are some alternative drugs. This table reveals selection of antibiotic based on gram-negative cocci organisms, including gonorrhea and meningitis. The first column, again, reveals the organism, the third is the first drug of choice, and the third are alternatives. As you can see, for meningococcus, you want to use a third-generation cephalosporin, and the other column provides other alternatives, including penicillin G and a fluoroquinolone. This column reveals the antibiotic based on gram-positive bacilli. The first column again reveals the organism, the second reveals the first drug of choice, and the third are some alternatives. So as you can see, for Listeria, you want to provide ampicillin or penicillin G, with or without gentamicin, and some alternatives including Bactrim. This table reveals selection of antibiotic based on enteric gram-negative bacilli. Again, first column reveals the bug, second column reveals the first drug of choice, and the third column reveals the alternative drug choices. This table reveals selection of antibiotic based on gram-negative bacilli. As you can see, there's H. pylori here. You want to give clarithromycin plus amoxicillin, plus a protein pump inhibitor. And alternative options include tetracycline plus metronidazole plus bismuth. Another option would be like a respiratory infection and bronchitis, which is listed on the slide. It says you want to give like a Bactrim, but then there are other options including augmentin or fluoroquinolone. This table reveals selection based on the chlamydia infection, first choices, and then alternatives as well. This table reviews echinocystis, which is the organism, and again, first drug options and alternative drug options. This table reviews the mycoplasms, including first line options and second line. This table reviews rickettsia, which includes like Rocky Mountain spotted fever. You want to give doxycycline as first line, and then alternatives listed on the right as well. All right, we made it to the end. The last table, it reviews Spirochetes, which is the organism. Again, first line options and alternatives on the right. Next, we're going to talk about empiric therapy. Now, empiric therapy is completed before completion of laboratory tests. Now, optimal antimicrobial therapy requires identification of the infecting organism and determination of its drug sensitivity. However, when a patient has a severe infection, we may have to initiate therapy before test results are available. Under these conditions, drug selection must be based on clinical evaluation and knowledge of which microbes are most likely to cause an infection at the particular site. Now, if necessary, a broad-spectrum agent can be used for initial therapy. Now, after the identification and drug sensitivity of the infecting organism has been determined, we can then switch to a more selective antibiotic. Now, when conditions demand that we start therapy in the absence of laboratory data, it's essential that samples of exudates and body fluids be obtained for culture before initiation of treatment. Now, the first rule of antimicrobial therapy is to match the drug with the bug. Hence, whenever possible, the infecting organism should be identified before starting treatment. However, if treatment is begun in the absence of a definitive diagnosis, positive identification should be established as soon as possible to permit adjustments of the regimen to better conform to which drug sensitivity of the infecting organism. Now, the quickest, simplest, and most versatile technique for identifying microorganisms is microscopic evaluation of a gram-stained preparation. Samples for examination can be obtained from exudate, sputum, urine, blood, and other body fluids. Now, the most useful samples are direct aspirates from the site of infection. In some cases, though, only a small number of infecting organisms will be present. Under these conditions, positive identification may require that microbes be grown out in a culture. As previously stressed, material for culture should be obtained before initiating treatment. Furthermore, the sample should be taken in a fashion that minimizes contamination with normal body flora. In addition, samples should not be exposed to low temperatures, antiseptics, or oxygen. Now, there is a relatively new method known as PCR testing or nucleic acid amplification, and this can detect very low titers of bacteria and viruses as well. In addition to matching the drug with the bug and determining drug sensitivity of an infecting organism, we must consider host factors when prescribing an antimicrobial drug. Two host factors, or host defenses at the infection site, are unique to selection of antibiotics. Other host factors such as age, pregnancy, and previous drug reactions are the same factors that must be considered when choosing any other drug. So for host defenses consist primarily of the immune system and phagocytic cells, macrophages, and neutrophils. Without the contribution of these defenses, successful antimicrobial therapy would be rare. In most cases, the drugs we use do not cure infection on their own. Rather, they work in concert with host defense systems to subdue an infection. We must also consider site of infection. To be effective, an antibiotic must be present at the site of infection in a concentration greater than the MIC. At some sites, drug penetration may be hampered, making it difficult to achieve the MIC. other host factors include previous allergic reaction or genetic factors. And specifically with the genetic factors, as with other drugs, responses to antibiotics can be influenced by the patient's genetic heritage, including the metabolism of the drug. Now this slide discusses antibiotic use across different ages. Specifically, when it comes to infants, they're highly vulnerable to drug toxicity. For children, we need to be wary of tetracyclines, for example. For pregnant women, we need to be aware of antimicrobial drugs that can cross the placenta. For breastfeeding women, we need to be aware of antibiotics that can enter breast milk. And for older adults, we need to be aware of heightened drug sensitivity and metabolism and drug excretion. Now, when thinking about dosage and duration of treatment, success requires that the antibiotic be present at the site of infection in an effective concentration for a sufficient time. Dosages should be adjusted to produce drug concentrations that are equal to or greater than the MIC for the infection being treated. Drug levels 4 to 8 times the MIC are often desirable. Duration of therapy depends on a number of variables, including the status of the host defenses, the site of infection, and the identity of the infecting organism. It's important that the patient obviously finish the prescribed course of antibiotics, though. Now, it's important to note that antibiotics can be combined. However, therapy with a combination of antimicrobial agents is indicated only in specific situations. Under these well-defined conditions, use of multiple drugs may be life-saving. However, it should be stressed that although antibiotic combinations do have a valuable therapeutic role, routine use of 2 or more antibiotics should be discouraged. Now, when an infection is caused by a single identified microbe, treatment with just one drug is the most appropriate. Disadvantages of antibiotic combinations include increased risk for toxic and allergic reactions, possible antagonism of antimicrobial effects, increased risk of superinfections, and selection of drug-resistant bacteria, and then increased cost as well. So reasons for antibiotic combinations include if the initial therapy is for a severe infection. Additionally, if there's mixed infections, another reason for prescribing multiple combinations would be if you're trying to prevent resistance. Lastly, for decreased toxicity, because in some situations an antibiotic combination can reduce toxicity to the host. And then actually one more reason is enhanced antimicrobial action. And in specific infections, a combination of antibiotics can actually have a greater antimicrobial action than a single agent. An example would be penicillin plus an aminoglycoside in the treatment of enterococcal endocarditis. Next, we're going to talk about prophylactic use of antimicrobial drugs. Estimates indicate that between 30 and 50% of antibiotics used in the United States are administered for prophylaxis. And really what this means is that these agents are given to prevent an infection rather than to treat an established infection. Most of the prophylactic use is actually uncalled for. However, in certain situations listed above, they are indicated. And this would be for surgery, bacterial endocarditis, neutropenia, and then there are other indications for antimicrobial prophylaxis, including for young women with a recent UTI. You can actually give prophylactic treatment to prevent another UTI, or for someone who's had a severe rheumatic endocarditis. This can also be an option to give on prophylactic treatment. Lastly, we're going to talk about misuse of antibiotics, which is incredibly common. According to the CDC, 1 in every 3 outpatient antibiotic prescriptions is either inappropriate or entirely unnecessary. And if you think about that 1 in every 3, that is just a large number. So there are ways of preventing misuse, and this is really just to prescribe antibiotics when they're indicated. When they're not indicated, you don't want to give antibiotics. So examples of this would be treating viral infections, treating fevers of unknown origin, treating without having all the information, including adequate bacteriological information, or obviously providing improper dosages. That's an important key as well. All right, we made it to the end. If you guys have any questions, please don't hesitate to contact me. My email is listed here, and I hope you enjoyed this lecture.